Thank you so much, Rachel. I appreciate it. So, thank you very much for joining us this evening. Tonight, we're going to cover BPH, a very common prostate problem in men. Um, just to let you know that after the presentation is over, we will find time for questions and answers. Here's my contact information. I'll put it up at the end of the slideshow. I appreciate Rachel giving me the introduction. So what we're going to cover today is the anatomy of the prostate as an overview. And we're going to talk about the pathophysiology of an enlarged prostate, also known as BPH or benign prostatic hyperplasia. After that, we'll go over the various treatment options for BPH. So let's go over the prostate first. And as an overview, the prostate is a walnut-sized gland, and it's in between the bladder and the male urethra where a man urinates from. So you have to think of the bladder as the organ that stores urine from the kidney. And when you're ready to urinate, the urine goes from the bladder through the prostate and out of the male penis or urethra. The prostate surrounds the urethra and only really is important for times of fertility, as it gives the semen fluid to change its pH. Normally, the prostate grows and is mature at around 20 years old, and it starts growing again and oftentimes becomes problematic at 40 years old. So there's different conditions that affect the prostate differently. The one that we're going to focus on tonight is the enlarged prostate gland, or benign prostatic hyperplasia. Prostatitis, which is an infection or inflammation of the prostate gland, is not going to be dealt with tonight. Neither is prostate cancer. But as a urologist, as we'll talk about in slides to come, it's important for our urologists to differentiate BPH, or an enlargement of the prostate, from infection or from prostate cancer. So what's BPH, and what does BPH stand for as an acronym? So BPH stands for benign, meaning not cancerous, prostatic, meaning occurring in that prostate area, and hyperplasia, meaning more cells than normal, but not cancerous cells. So the prostate gland is typically measured at 1.5 inches in diameter, and really that's correlating to a size of about 20 cubic centimeters or 20 grams. As the prostate gets larger, it causes a blockage that could lead to lower urinary tract symptoms. It's important, like I said in the prostate slide before, that BPH is not prostate cancer, and it does not cause prostate cancer. There are times where BPH symptoms may be similar to those of cancer, but it's usually advanced cancer, because cancer that's localized to the prostate has no symptoms. So BPH may coexist with prostate cancer as well, even though they're two separate identities. Prostate-specific antigen, which is a blood test, cannot tell the difference between BPH or prostate cancer. And that's why it's very important to have a urologist work you up for these prostate conditions, because you want to differentiate an enlargement of the prostate from cancerous prostate tissue. So this is a great animation, or a great diagram, which shows the prostate in its normal and abnormal enlarged state. In the normal state, you can see the bladder has some urine in it, and the green arrow shows that it has to go through the prostate into the male urethra for the expellation of urine. However, in the enlarged prostate, you see how it pinches the urethra and doesn't let the urine through as effectively. And oftentimes this can scar or damage the bladder and cause the bladder to thicken. And that's because as the prostate enlarges, pressure is put on the urethra. And this pressure causes lower urinary tract symptoms, which we'll go through on the next slide. What's important is that prostate size. Now, this is really, you have to wrap your head around this. Prostate size does not always correlate with the degree of obstruction or the severity of symptoms. And the reasoning is the prostate may grow outward and not inward. And if it's growing outward, it's not going to cause blockage and is not going to cause urinary symptoms because you don't have that blockage. So for the prostate to really cause these lower urinary tract symptoms, you have to be pinching or growing into the urethral portion of the prostate. So what are some of these symptoms that men see as the prostate grows from the 40 years on, the year 40 year on? And what you typically see is frequent urination during the day and also frequent urination possibly at night, called nocturia. You might have a sudden urge to urinate. You might have a weak flow. You might not empty the bladder completely. Oftentimes you may dribble after you urinate, or you might have trouble starting and stopping urinary flow. In the most extreme case, you can't urinate at all, where you would need to have a catheter put in. Men that suffer from benign prostatic hyperplasia oftentimes have an quality of life issue because of the constant need to try to find the bathroom. And 95% of men with moderate symptoms will say they're unhappy and don't want to spend the rest of their lives with their symptoms. 51% of men say that the benign prostatic growth is interfering with their normal activities of life. So much so where oftentimes they'll plan where the bathrooms are so they can get there in time if they're going out for social events, let's say. 49% of men also experience sexual problems associated with lower urinary tract symptoms. And that's oftentimes because as the prostate grows, it could be stretching on the nerves for the erections. BPH doesn't only cause trouble towards one's life, it also affects a man's partner, because oftentimes the partner might be with them when a man is seeking to go to the restroom, whether at daytime or nighttime, and it could affect a relationship because of that. BPH, or benign prostatic hyperplasia, or an enlargement of the prostate, is the most common prostate problem in men greater than 50. It affects about 1/2 of men by the time a man is 60 years old. And by the time a man's 85 years old, 90% of men will be affected by this. And about as about 14 to 20 million people in the country complain of lower urinary tract symptoms. Oftentimes, a sedentary lifestyle, whether it be obesity or lack of exercise, can increase the risk of an enlarged prostate. So how does a urologist start to work up an enlarged prostate? The first is medical history and doing a physical exam. And the medical history oftentimes takes the questionnaires that might come out by different societies that talk about urgency, frequency, waking up at night, leaking, or possibly burning of urination, and turns that into medical history. Oftentimes, for prostate cancer screening, we'll get a prostate-specific antigen test. We'll do a rectal exam to see if there's any nodules. And we'll also do some urine tests to check the flow of urine to see how fast you're urinating or expelling your urine. At the end of that test, we will scan the bladder to see how much urine is left over into the bladder when you try to go to the bathroom or do go to the bathroom. And if you're retaining a lot of urine, that oftentimes is a sign of prostate damage or bladder damage because of the prostate. So we're going to go through the many treatment options out there for a benign prostatic hyperplasia or an enlargement of the prostate. And these include behavioral changes, including, let's say, timed voiding or avoiding liquids before bedtime or doing bladder Kegels to maintain continence. And it could go towards after that first line therapies, which are really the first thing that us as urologists will offer to patients, in that it's minimally invasive therapies for the prostate. Those include 2 different types of medications, which we'll be talking about. It includes water vapor steam therapy, which you could inject into the prostate. It also includes implants into the prostate tissue, which anchor the prostate open. And then you can go to real surgical procedures like lasering, scraping, or doing an incision and excision of the prostate, which is called a prostatectomy. Of course, if you look at the level of invasiveness, behavioral modification would be the least invasive, whereas the water therapy and the implants and the medications really would fall into a medium zone level of invasiveness, and where prostatectomy or scraping or lasering the prostate would be much more invasive. So according to the American Urological Association, there's no dietary supplement or phytotherapy or non-conventional therapy that is recommended for the treatment of lower urinary tract symptoms because of BPH. This includes some of the more popular herbal therapies, including saw palmetto or Uritica, which is stinging, or the settle needle therapy. And none of those therapies have been recommended by the American Urological Associations as of yet. But what else can you do? You can watch and do a watchful waiting of your prostate symptoms, meaning you don't take medication, but you see a urologist and you discuss if your prostate issues are progressing to a point of becoming bothersome in your life. Only about 20% of men are satisfied with just lifestyle changes of their prostate, which may include cutting back caffeine, cutting back sugars, cutting back spicy foods, all of these bladder triggers. The one thing that you have to be cognizant of is that if you're not treating the prostate and the bladder's under a lot of pressure, the bladder can thicken and scar up and can become damaged as the years go on. And a lot of the scarring and damage might be non-reversible, no matter what procedure you might be thinking of having. Another thing is, as the prostate continues to grow, some of these minimally invasive procedures, including the vapor therapy or the anchoring therapy, might not be as available anymore as the larger prostates come about. Those therapies are not a great option anymore for certain size prostates. So what's the medications that we give for an enlarged prostate? There's 2 types. One of them is an alpha blocker, and the other type is a 5-alpha reductase inhibitor. Alpha blockers are very, very common. They include medications like Rapaflo or Flomax. And what these medications do is they basically allow the prostate and the muscles in the bladder to relax, which lets urine out more freely. This does not cause the prostate to shrink or prevent the prostate from regrowing. It just relaxes the prostate. As a caveat, only about 30% of people taking medications continue to do so within a year, with about 71% of men stopping their medications within 1 year. The side effects of the medicines are not too bad with the alpha blockers, typically facial flushing, drops in blood pressures, and you might have some interactions with other medications, including medications for erection like Viagra or Cialis or Levitra. But these are the first line medications that we give, and they're pretty well tolerated. But once again, I consider it a Band-Aid because it's not causing the prostate to shrink and it's not preventing the prostate from regrowing. Over time, the prostate is going to continue to grow, and you might have more and more bothersome symptoms despite being on the medication. In contrast to the alpha blockers, the other type of medication that we have are called 5-alpha reductase inhibitors. These are the Avodarts out there, finasteride, dutasteride. Jalin has a component of dutasteride in it as well and can be lumped into the 5-alpha reductase inhibitor. And unlike the alpha blocker, this is a medicine that's designed to stop the growth or shrink the prostate. And the way it does that is it prevents testosterone from converting into DHT or dihydrotestosterone, which causes the prostate to grow. So by blocking the testosterone converting to dihydrotestosterone, typically men will see about a 40% shrinkage in their prostate, and they'll have, after that shrinkage, if they continue the medication, the prostate won't continue to grow. This is at the expense of some significant side effects. And the ones that are pretty significant are especially erectile dysfunction and decreased libido, as well as ejaculation that might be lower volume or drier. You could also get gynecomastia from this hormonal medicine, and gynecomastia is breast enlargement. Once again, 71% of men stop taking these medications within the first year, but the positive aspect of it is that it's not a surgery, and we do give it to older men that are not sexually active as a possible means of treating the prostate. Very, very much, I would say, we are stepping away from giving finasteride or dutasteride to men that are sexually active. The first major outpatient minimally invasive surgical therapy is called the Rezum water vapor therapy, which is one of my favorite procedures out there. It's an outpatient therapy that uses the energy in steam to shrink the excess prostate tissue. It does not require general anesthesia, although in our office we do use conscious sedation. It has one of the lowest surgical retreatment rates out there, and you'll see the different retreatment rates based on the different procedures. And this one's about 4.4% through 5 years. Side effect wise, it's extremely well tolerated with burning or pain or some blood in the urine as being minor side effects that typically go away afterwards. You can have a decrease in the ejaculatory volume, but will infrequently see any type of erectile damage or erectile dysfunction from a Rezum treatment. So here you can see the schematic of an enlarged prostate on the top, and then on the bottom is what the Rezum therapy would be like after you inject the big areas of tissue with steam. And what basically happens is after injecting it with a needle and injecting steam into it, the prostate initially swells up, but the prostate cells can't stay swollen and they'll burst. In a period of 2 or 3 weeks, those cells will then cause the prostate to contract and open up the prostate channel so a man can go about urinating as he used to. One of the best ways to know whether or not a surgery or procedure went well is by asking a patient if they would recommend a procedure to a friend. And about 90%, 97% of men would recommend this procedure to a man or a counterpart. And that's a really great number, really high number. What's the other office procedure that we do that's commonly used? And that's called the prostatic urethral lift, also known as a urolift. And what that does is it places anchors to push back the enlarged prostate tissue out of the way. So it basically lifts and pushes away the prostate tissue. It is a permanent implant. It once again doesn't require general anesthesia, but the retreatment rate here is much higher than that 4.4%. And you're seeing about almost a 14% retreatment rate at 5 years. A lot of the side effects are the same. It doesn't have the erectile dysfunction side effects or the retrograde ejaculation or dry ejaculation side effects as many of the other more advanced surgical therapies might have. So what are some of these surgical therapies that are typically done in the hospital or surgery center? One of the more common ones that we like doing is called a green light laser therapy of the prostate. And that that does is it uses green light, which is absorbed by blood and bloody tissue like prostate tissue, very vascular tissue. It absorbs it and basically it vaporizes and turns the solid into gas and vaporizes away your prostate tissue. Once again, great surgical retreatment rate here, 4.8% for 5 years. But this in-hospital or in-surgery center procedure does have a longer list of potential side effects. And some of the larger ones and longer ones or longer lasting ones are scarring and narrowing of the bladder neck or of the urethra. And some patients even can have damage to the sphincter, which can cause urinary leakage or incontinence. The dry orgasm rate or retrograde ejaculation rate is very high here at about 60 to 65% of patients complaining of dry ejaculations. Here you could see basically how a green light once again would work. You go up to that enlarged tissue on both sides and you take the laser and you go directly a couple millimeters away from the tissue and the laser will laser away this excess tissue. So what's the next therapy here that we're going to talk about? This is the rotor-rootering that we've all heard about, what we used to do back in the days. It uses a heated wire to cut tissue from the prostate. With this procedure, just like with the green light laser vaporization, it is a surgery. You do require anesthesia. It has a low retreatment rate of 5.8%, but once again, scarring of the urethra, scarring of the bladder neck, urinary incontinence, and a 65% chance that you're going to have dry ejaculation or retrograde ejaculation. Next, we're going into something that is really anecdotal here because we don't really do it much anymore. And that's called a prostatectomy or a surgical removal of the prostate gland. It's an outpatient procedure. However, most of the times you are admitted into the hospital for this procedure and you'll be in the hospital for a couple of days. Typically, it's done by a robot or it's done with an incision underneath the belly button, and a good portion of their inner aspect of the prostate is removed. It's not the whole prostate, but it's a good majority of the prostate tissue blocking the urethra. Once again, this is a big surgery. Transfusions now become an issue. Severe infections become an issue. Narrowing, scarring of the bladder, or narrowing or scarring of the urethra or prostatic channels, once again, are all issues. The iTind is another therapy that is something that we'll talk about. And this is a newer type of therapy. It's an implantable nitinol device that you put in for about 1 week into the prostatic channel. And what that does is it causes a compression that in effect kills the prostatic cells around the area that's being compressed. It's new. It has not been widely adopted into the urological community as of yet. It does cause pelvic pain in patients while they have it, or even after they might have the iTind procedure. They might also have significant urgency or frequency or feeling of a pressure in that area. Typically, we give it to patients that are not good candidates for surgery or procedures that we have spoken to as of yet. Another innovative therapy out there that has just came out is called aquablation therapy. And this basically uses a robot to take pressurized fluid and put it into a jet to remove away the prostate tissue. The earlier studies of this have been shown to lead to a bunch of bleeding and takebacks in the operating room, but they're still going through their learning curve of learning how to do this procedure. So it's one that we're still waiting on some good data to come about from urologists as they start learning or going through their learning curve. The transurethral needle ablation of the prostate, or TUNA, uses radio frequencies with needles to go into the prostate tissue. And instead of putting steam, you're putting radio waves. And we basically stopped doing this procedure as about 1/4 of the patients that had it have to go back to the operating room within 5 years for a retreatment. So in summary, we learned what the prostate does, where the prostate is, how the prostate works, and what the enlarged prostate does and means, including the term benign prostatic hyperplasia. The two big first-line therapies we discussed, the resume water vaporization therapy and the permanent implants, have become very highly adopted in-office procedures with excellent success rates, very, very similar to the success rates of surgical procedures, including resection of the prostate or laser vaporization of the prostate. So really the next thing to do is, if you're having some of these issues with benign enlargement of the prostate, is really to contact your urologist and determine which is best for you. And oftentimes that's a one-on-one and unique therapy for each patient, depending on how big the patient's prostate gland is and how severe their symptoms are. If anyone has questions at this point, you could put it into the chat box and Rachel can read it off for you.